Hello, everyone, and welcome to today's CalMap webinar on the treatment and assessment of substance use disorders in youth. My name is Joanne Jung, General Pediatrician, Senior Associate Director at CalMap. And let's start digging into a few of our announcements quickly for today with the next slide. Just a quick reminder that we are available for individual consultations, so please feel free to call us at these office hours. If you've got particular questions for your patients, it's almost real-time consultation with our psychiatrists. We also have clinical psychologists who can give you very targeted advice on specific disorders like autism and substance use, as well as resource navigation support if you're looking for resources like where's a good substance use treatment program for my youth. Next slide, please. And then a quick reminder of some of our upcoming educational events. Our next webinar in 2 weeks will cover motivational interviewing, which should be great. For primary care providers looking for case-based discussion, we have one on eating disorders coming up next Wednesday, and another case-based discussion more for school-based staff on substance use happening later in the afternoon on the same day. Finally, towards the end of the month, we'll be talking about interaction cycles and our therapeutic skills Project Echo as well. Next slide, please. Quick word on our disclosures and our funding sources that you can review here. We have no relevant commercial financial conflicts of interest to disclose. We do have some federal and state funding. You can take a quick look at some of our funders here. And then with that, I would like to introduce our speaker for today. Dr. Emily Tejani is a physician board certified in 3 different medical specialties: adult psychiatry, child and adolescent psychiatry, and addiction medicine. She has a long-standing private practice in Marin County where she specializes in providing family-based consultation and treatment for youth and adults experiencing psychiatric and substance use disorders. She previously worked at the University of California, San Francisco, where she helped to develop a youth and young adult outpatient substance use program as part of the California Youth Opioid Response. Prior to her time in California, she was the National Institute of Drug Abuse Research Fellow at Yale University, and in addition to her clinical work, she has worked as an expert witness on federal opioid litigation, and she regularly provides mentorship, training, and consultation through organizations such as SAMHSA's Opioid Response Network and the University of California, San Francisco, and the American Academy of Addiction Psychiatry. Dr. Tejani will be speaking on youth substance use disorders today. As usual, we'll be reserving the last 10 to 15 minutes for audience question and answer. So please feel free to type your questions for our speaker into the Q&A portion of the Zoom controls. And with that, it's a pleasure to turn the virtual mic over to Dr. Tejani.
Thank you, Joan, and thank you so much for everyone who's joining us today. Here's a list of our learning objectives for the day. And just some quick definitions. You may hear me say SU or substance use. With that, I'm referring to one or more instances of using a substance, but not necessarily a disorder or an addiction. If you hear me say SUD or substance use disorder, I'm referring to the clinical diagnosis that is made when someone is showing the signs and symptoms of this clinical condition. And sometimes this term is used interchangeably with the more colloquial term of an addiction or addictive disorder. And then I may go back and forth between the term psychiatric disorder or psychological distress to refer to emotional, cognitive, and/or behavioral symptoms that are causing distress and functional impairment. And when these occur alongside SUD, we sometimes call that a co-occurring disorder, meaning there's psychiatric symptoms along with addictive or substance use disorder symptoms. So for everyone who is here today, again, thank you. We really need all hands on deck when it comes to this topic of adolescent and young adult substance use and substance use disorders. Drug overdose is currently and has for many years been the leading cause of death in the United States. For individuals younger than age 50, it's been contributing to a declining life expectancy. California unfortunately has no coordinated system of care for youth SUD treatment. And while we do have effective evidence-based treatments for SUDs, only 10% of youth will receive any treatment. And of those 10%, only about a third will receive treatment that is evidence-based. The more we can kind of coordinate and collaborate between psychiatry, SUD, specialty services, and primary care services, the more we're going to be able to meet the needs of youth in California and in the country at large. Another reason this is really an important and timely topic is that unintentional drug overdose death rates have really spiked over the past few years amongst youth, adolescents specifically. And youth aged 15 to 19 have, for several years in a row, been the group amongst our population at large that has experienced the greatest increase in unintentional overdose deaths. This is largely due to fentanyl and opioid related overdoses. So this is a real sort of life or matter issue right now and has been for some time now. Another reason it's important for those working with youth in pediatric, primary care, or other settings to be familiar with the diagnosis, prevention, and treatment of SUDs is that these really are disorders that begin to manifest in adolescence. As you can see on this graph, rates of new onset SUD begin climbing throughout the high school and adolescent years, kind of peaking during the emerging adult or young adult years, and tend to persist generally for a decade or more, with rates of remission sort of increasing during that 30s to 40s period. And substance use disorders truly are developmental disorders. There are a variety of risk factors and protective factors, both biological and environmental, both nature and nurture, that exist at every sort of major developmental period, all the way from preconception up until young adulthood. So there are many opportunities to intervene and affect change with regard to SUD risk and prevalence for anyone who is working with any child, even infants and their parents, all the way up to those college age, transitional age youth. The primary developmental factors, risk factors for substance use disorders, involve co-occurring or psychiatric disorders, as you can see on this bar graph here. Individuals who, youth who had a past year SUD diagnosis were much more likely to also have a past year major depressive disorder diagnosis. We also know that high ACEs, early life trauma and stressors, are predictive of much greater SUD risk later in life. And there are both biological and environmental risk factors related to family history, as well as current parental SUD. There are other risk factors as well, but these are some of the most important and impactful ones. I think it's helpful to recognize that there are certain childhood symptoms or temperamental traits that are also predictive of greater risk of both initiating substance use at an earlier age as well as escalating to a substance use disorder. And this graph here is from a study that was done a few years ago that used machine learning to identify a sort of SUD prodrome. You may be familiar with prodromal features of other psychiatric disorders, and this has not been talked about quite as much with regard to SUD, but for folks working with kids or tweens, I think it can be helpful to kind of be aware of what features might we see more in some kids versus others that may result in them sort of being a higher risk group and in need perhaps of a little more screening and intervention. And so you could read through this list here. They include things like, do you swear often or use bad language? Did you run away often from home? Are you touchy or easily annoyed? Did you have a lot of headaches? Were you sort of inattentive? What did people notice you were daydreaming a lot as a child? And these are all symptoms that were present at age 10 to 12, so prior to the age that people would generally start using substances, although it can happen at that age or sooner. And these largely are likely signs of either emerging or current either psychiatric disorders, such as perhaps ADHD, or major depressive disorder, difficulties with impulsivity. So these are things that are very concrete that you might kind of keep an eye out for when families are coming in for just general checkups. Some other important risk factors and things to be aware of and kind of on the lookout for as families come in talking about their life and their concerns that are impactful with regard to SUD risk include an environmental factor that's very important, drug availability. We know that the more prevalent and easily obtainable a substance is in a society, the greater the risk of individuals developing a use disorder with that specific substance. So it's no surprise that alcohol is the most prevalent SUD in our country. Alcohol tends to be the most widely available and accessible substance with the greatest number of people using it. Earlier age of first substance use is also strongly associated with and predictive of greater risk of later SUD, as you can see on this graph here, which breaks down risk by whether someone has a family history of alcohol use disorder or not. You can see even in those individuals who do not have a positive family history, earlier age of first alcohol use is strongly correlated with greater risk of developing an alcohol use disorder or alcohol addiction. So helping youth and helping parents to be aware that it's important for youth to delay their first use as much as possible. It makes such a big difference with regard to reducing the risk that they'll develop a pattern of problematic use. And then frequency of SU is another important risk factor. The more often someone is using a substance, the greater the risk becomes of developing a disorder or addiction to that substance. So I'm going to go kind of quickly through the physiology of addiction. There's just a few important points I want to make that I think can be helpful to understand and hold in mind when working with individuals who are either in the process of developing an SUD or who are in need of treatment and seeking help or struggling maybe to even motivate to seek help for their SUD. The first really important one is that we all really are wired for addiction. Sometimes people will talk about an addictive personality. And while it's true that there are some traits, as I mentioned earlier, and some co-occurring conditions that increase the risk of developing an SUD, truly anyone can develop an SUD. And that is because we all have these centers in the brain pictured here, namely the reward pathway and associated structures that when stimulated sufficiently with a drug that has an addictive potential can result in an addiction developing. What varies from individual to individual is the frequency and amount or dose of drug required to sort of tip that balance toward non-problematic use to an actual SUD. An addictive drug is any substance that elicits a strong burst of dopamine along the reward pathway. And I just mentioned this to point out that many drugs, namely prescription drugs, are not addictive because they do not stimulate the reward pathway in this way. And sometimes that's an important point to be aware of when talking to youth about why it might be helpful to be on a medication as opposed to using an addictive drug to self-medicate. Because self-medication can sometimes work in the short run, but will never work sustainably in the long run. Another important point is that the reward pathway really isn't so much about pleasure as it is about motivation and drive. The pleasure centers that get stimulated that cause this sort of euphoria or liking effect that some people experience when using an addictive drug are related to but distinct from the circuitry that's involved in that habitual repetitive behavior. And I think just sort of knowing this and appreciating that once an addiction or an SUD has set in, that someone is experiencing a very strong drive toward using, that it can be totally separate from any joy that is occurring at that point of using, is helpful, because many times people are really suffering and they're not using so much to feel better than normal. They're often using because it has become sort of wired into their brain that that is what they need to do sort of in order to survive and get through the day. And the reward pathway likely developed during evolution as a way to help us sort of seek out and do the things that we need to do to stay alive and procreate. It's the same pathway that gets stimulated when we eat or fall in love or mate or have sex. And so it's really telling us that's important. Let's do it again, not, ooh, that feels good. Um, Go through this part a little more quickly. A key point here is that continued drug use pushes the brain and the body past our homeostatic set points and causes distinct alterations in key regions of the brain that affect how we feel, how we think, and how we act. And this is because a stress response or an allostatic response sets in due to the fact that addictive drugs cause greater than expected increases in dopamine and stimulation along that reward pathway. And so with sustained use of any addictive drug, doesn't matter which type of drug it is, will lead to impairments in the prefrontal cortex. So there is increasingly impaired executive functioning, greater impulsivity, greater difficulty thinking through one's best course of action before actually acting. There are also significant alterations and impairments that happen in the amygdala and the mood center of the brain, such that an individual develops more dysphoria or low mood and more anxiety, particularly whenever there's any abstinence from that drug. And there are impairments that happen in the stress system, such that an individual becomes less resilient to stress and more reactive to stressful situations, which is likely a big part of why any sort of external stressor can be such a strong trigger for relapse, especially during the period of early sobriety. I want to point out here that addiction or SUD, the recurrent return, the return to substance use despite consequences or problems that one is experiencing due to that substance use, it's really not driven by physical withdrawal symptoms. Sometimes people think if I can just get through those first few days or week or two of physical withdrawal, then I'll be okay and I should be able to go out there in the world without having craving or being tempted to use again. But unfortunately, it's not so simple. There is a syndrome of psychological withdrawal, would be one way to think about it, that also exists because of everything I mentioned about those impairments in executive functioning, mood, and stress reactivity. And those changes tend to persist for much longer than the physical withdrawal period. The exact duration with which those changes are present for varies from individual to individual and often is somewhat correlated with the amount of time that a person had been using the substance. But these are really what tend to drive most people back into a recurrence of their SUD. And, you know, being patient and having a lot of support during that period, those first few months or year or longer, can really help individuals who are struggling with this. Um, you know, youth are really especially susceptible to these drug-induced changes in brain structure and function because their brain is more malleable, it's more neuroplastic, which is great when you know, they're out there sort of doing typical adolescent things and needing to like learn how to survive in the world, but it does really put them at risk for profound and persistent impairments when drug use occurs during that developmental period. And there's some research to suggest that it can be harder or take longer later in life to sort of repair some of these impairments or alterations than if someone is developing an SUD later in life during the adult years when the brain has become less plastic. This is just sort of describing something I mentioned earlier. I have this picture here to sort of illustrate how confusing it can sometimes be for patients and even for clinicians to disentangle what is a drug withdrawal symptom versus what is something that was maybe there before the drug use began that an individual thinks the drug was helping with. And this comes up a lot with cannabis use disorder, probably because the symptoms of cannabis withdrawal can be a little more subtle than the withdrawal symptoms we might see with other substances such as alcohol or opioids. And it can really take some time for those withdrawal symptoms to abate. And commonly people will because that sort of temporal dissociation and symptom and relief, they will begin to associate use of the substance with sort of improvement in some sort of symptom. It might be they think the cannabis is reducing their irritability or their anxiety or their insomnia, or some of the other things listed here. Um, and while many individuals may have experienced these symptoms before they started using cannabis due to perhaps a psychiatric disorder or some sort of stressor in their life, cannabis undeniably will exacerbate or can even cause all of these symptoms once someone has become dependent on cannabis. And being able to kind of talk about that and for individuals to know that it's normal to get more irritable, more anxious, to have more insomnia during that early period of abstinence from cannabis or from other drugs, if we're talking about a different SUD, can really help with, again, sort of keeping the faith that it makes sense to kind of continue with abstinence during a period that may be tremendously difficult and painful physically or psychologically. And I just love this quote by David Foster Wallace about addiction is when the drug offers itself as relief from the very problem it causes. Because an SUD, the onset tends to be, kind of insidious, it can be really confusing to remember that one did feel better at one point before the SUD developed. And it can be especially confusing when you're working with an individual who has a co-occurring psychiatric disorder, because likely they were struggling or suffering with symptoms even before the SUD developed, but in pretty much every case, the SUD has made things worse, and it can be helpful to kind of draw a timeline out together and look at that and sort of evaluate together, have things gotten worse or better over the months or years that the SUD has been present. So what can pediatricians or primary care providers or others sort of working frontline with youth do? Um, just sort of bringing this into everyone's conscious awareness can be really helpful. That can be done by routinely asking about family history of mental health disorders or substance use disorders. Asking about parental substance use can also be helpful. It just sort of puts this topic on someone's radar and also makes it known that this is a topic that can be talked about in here, wherever you are working with families, whether it's a teen or a parent. Doing what you can to weave in anticipatory guidance regarding SUD prevention, and we'll talk more about what that guidance is in a minute here. And then routinely screening and, if you feel comfortable doing so, diagnosing adolescents for substance use disorder using a validated screening tool. And then being familiar with the evidence-based treatment options for youth and families. Um, because of our at times siloed healthcare system, sometimes parents don't know that this is something that they can go to a pediatrician or a primary care provider too, with, that they may sort of look outside the healthcare system, and sometimes they might find things that are helpful, but unfortunately there are a lot of non-evidence based um, uh, things happening out there. And when someone looks outside of a healthcare system, there's a greater risk of going down a pathway that may not only not be productive, but could potentially be harmful. There are strategies that people employ that can cause iatrogenic harm and make substance use disorders worse. So we want to help people avoid that. And then knowing how and when to refer to appropriate levels and types of care. So let's talk about universal primary prevention. Um, this is prevention guidance that is aimed at helping sort of everyone delay initiation of substance use and knowing how to kind of reduce the onset of not only substance use, but also a substance use disorder. And here's where psychoeducation with both youth and parents tends to be really helpful. So what you'll see here is a line graph showing how no knowledge of the risks that come with using substances, particularly at a young age, can help to reduce onset of first substance use or progression to more frequent substance use and substance use disorder. Knowledge is not so helpful as a treatment when someone already has the onset of a substance use disorder, but amongst individuals who are younger and haven't started using yet or are using very infrequently, giving them real sound, honest information about the potential harms that can come with using a substance, especially at a young age, is strongly correlated with reduced likelihood of use. So you can see that there is a opposite relationship here between perceived risk of marijuana use and rates of annual marijuana use amongst 12th graders. And this is a strong and well-known relationship that exists. Another thing that I found to be quite helpful is to emphasize to parents that they can be having these conversations at home and also that actions often speak louder than words. Um, there's a lot of messaging and movies and advertisements that show, a rosy side of, say, alcohol use disorder, or maybe it's cannabis, or sorry, not use disorder, but alcohol use or cannabis use. And when youth see parents using alcohol frequently or whenever there's sort of a social or celebratory occasion, it doesn't tend to send a message that there are harms or downsides to using those substances. So I think it's important to kind of, gently get parents sort of thinking about this. And if you're working with a family where there's a known history of substance use disorders in that family, that can really be a nice sort of gateway into having these discussions and talking about, sort of changing that pattern and how to do so. Just a little information here about Iceland as an example of how effective preventative measures can be when it comes to population rates of youth SUD. Iceland in the late 90s had amongst the highest rates of adolescent substance use disorders in the world. And over a 20-year period, they dramatically reversed that epidemiological trend, and past month rates of drunkenness amongst youth went from 42% to 5%. And we also saw reductions in other substance use. And the way they did that was through a public health campaign called Naturally High that involved four cornerstone approaches. One was to help youth find their natural high. There are many naturally rewarding things out there in this world that will compete with and reduce the ability of addictive drugs to kind of take over that reward pathway. So they invested in after-school programming and activities and hobbies for youth, making those easier to access. They emphasized the importance of healthy social connections. Social interaction is amongst the most rewarding non-drug reinforcers. So helping youth and families remember how important social engagement and having healthy friendships and family relationships is. They created guardrails as a community, enforcing a youth curfew, so helping parents remember that certain limits and sort of parental monitoring is important and effective. And then they also addressed social, emotional, or psychological factors through universal programming aimed at helping youth learn to better regulate their emotions and develop their social skills. Um, Beyond universal prevention, sort of the next layer of prevention we would think about is a primary prevention, and these are approaches that are used with certain indicated or target populations that may be at higher risk. So here we would be thinking about individuals who have those primary risk factors, such as high ACEs or family history or the presence of a psychiatric disorder, particularly psychiatric disorders that are strongly associated with risk of SUDs, such as bipolar disorder, ADHD, major depressive disorder. And we would spend a little more time with those individuals, making sure to screen everyone in this category and making sure that resources and referrals are provided to address some of these risk factors whenever possible and indicated. As you can see here, similar to what we saw with alcohol use or alcohol use disorder and major depressive disorder, there's also a strong relationship between past year depression and past month cannabis use amongst youth. And what we see here is some evidence or indication that early treatment of certain psychiatric disorders may actually mitigate or reduce the risk of later developing an SUD. And this is a study that prospectively followed individuals who were diagnosed with ADHD in childhood and grouped them based on how early and intensive they were treated with medication for that ADHD, and then followed up to look at rates of SUD as they went into adolescence. And you can see that the group of individuals with ADHD who received early and intense, meaning they were very adherent to their ADHD medication regimen, were significantly less likely to be developing a substance use disorder during these adolescent and young adult years than the individuals who began medication later or didn't take it as persistently. How about indicated prevention? This involves identifying youth with early onset SU, youth who might be right at that cusp of transitioning sort of from having some substance use to actually having signs and symptoms of a substance use disorder. And for this group, we want to not only screen and consider diagnosis, but also provide guidance and referral to treatment. Here are a couple good screening tools. There's the S2BI and the BStat. These are both open source. You can Google it and find them online. They can be done verbally or electronically or on paper and are really straightforward and are a great first step. Another great option, perhaps an even better option, is the craft, which many of you may be familiar with. The nice thing about craft is it goes a little bit deeper than these other screening tools and can help with estimating a sort of the degree of problematic use present. And as you can see here, increasingly higher craft scores are proportionally correlated with increasing likelihood of an individual actually meeting criteria for a DSM-5 substance use disorder. So while it's not a diagnostic scale or tool, it is a more in-depth screen that can kind of help with figuring out a little bit more clearly perhaps the level of care or the degree of support and type of referral that might be indicated for an individual patient. With regard to SUD diagnosis, I'm not going to get us all bogged down into the detailed diagnostic criteria, but I just want to point out that substance use, even at high frequency, does not necessarily translate to a substance use disorder. So all of the diagnostic criteria involved in making a diagnosis of SUD has to do with impairment and the degree of impairment or change that has set in. And while it is true that higher doses and greater frequency of substance use is related to greater likelihood of having an SUD and greater severity of SUD, we really want to be thinking about, is this person's health and behavior changing because of the SU, and if so, to what extent? And you can look up this criteria and the number of factors required to meet either a mild, a moderate, or a severe diagnosis. Um, let's talk just very briefly about how to talk to teens about this. It can be helpful to talk to parents. Often parents will be the ones coming in reporting concerns. And it's great to, get that information, those reports from parents, and you can use that information in your discussion with teens, showing, curiosity about why might their parents be coming to you with these concerns. But it's also really important to spend some time alone with the teen, asking not only about, are they using, but to get a little sense of when did they start using, how frequently have they been using, and why do they use? I think this is such an important question to, as non-judgmentally as possible, show some interest in why this is something they're doing. And that really ends up often being a nice portal into them feeling more comfortable sharing with you what's going on in their life. And I haven't yet met a teen who didn't have, something more than, I just like what it feels like to be on the drug, behind why they are using in a problematic way. And if you can show some empathy around that and some curiosity about what their actual lived experience is like, that really leads to a lot of goodwill and can help with greater engagement in treatment and in the referrals that are made. I also want to point out that research has shown that when a pediatrician makes a warm referral to a higher level of care or specialty care, there's much greater rates of the patient actually engaging with that specialty care and better outcomes with regard to SUDs and psychiatric disorders. So something as simple as, um, thanks for answering these questions. It sounds like these are some of the concerns or difficulties you're struggling with. I'd like to share these results with someone who has some more expertise and might be able to help with these things. They would give you a quick call. Is it okay if I do that? To let them know that you're going to be reaching out personally and that someone will be following up with them can make really all the difference. With regard to specialty treatment services, there are many different levels of care. There's outpatient services, there's intensive outpatient, partial hospitalization services, residential inpatient, and medically managed withdrawal. ASAM has some nice resources if you want to kind of look into and get more detailed criteria about which level of care may be indicated. But generally, all of the recommendations are to connect someone with the least restrictive level of care possible. I want to emphasize the fact that treatment works. Youth SUD outcomes are roughly similar to other chronic illness outcomes, and about 25 to 40% of youth in treatment will go into recovery and stay in recovery. But this does tend to be a chronic condition, and it's important that the intensity and duration of treatment is appropriate for the degree of impairment or severity of the condition that the individual is experiencing. Treatments generally involve one of three categories. There are a number of medications that can help both with treating withdrawal as well as with treating the SUD and reducing risk of recurrence or relapse. Therapy is another cornerstone of treatment, perhaps the most important cornerstone of treatment. Ideally, therapy should be family-based and involve both individual and parental and family sessions. And then there are a number of things that can be helpful that might occur outside of the clinical environment: social supports, recovery groups, and different environmental modifications. Here's a list of evidence-based medications for youth SUD. So as you can see, there are a number of medications that can help with tobacco use disorder, alcohol use disorder, opioid use disorder, cannabis use disorder. happy to answer questions about any of these. I do want to point out, given the accidental overdose epidemic that's currently occurring amongst teenagers, is that we do have medications that have very strong evidence for reducing not only opioid use disorder, but also opioid-related overdose death. And one of those medications, buprenorphine or Suboxone, is FDA approved in individuals 16 and up, and there's evidence to support its use in individuals even younger than that. And an individual does not need to be in therapy in order to benefit from these medications. Sometimes, people have this idea that you need to do the whole package of treatment in order for it to be effective at all, and that's just not the case. Something is truly better than nothing, and that's what this study shows, which you can look into in more detail later if you're interested. With regard to drug testing really shouldn't play a role with regard to screening or diagnosis. There's a number of reasons that the urine drug test is not going to be accurate or informative enough to make a diagnosis. It's really more something that can be used during treatment in order to enhance motivation and help parents or treatment providers reinforce behavior with positive reinforcement or rewards for negative drug tests, and to kind of monitor response to treatment. And it should only be done with the youth's awareness and consent. I also just want to point out that there are a number of outcomes to look for in treatment. We're not just looking for reduced substance use or abstinence. That can often take quite some time to achieve, but we're looking for retention and engagement in treatment. Individuals who stay in treatment are much more likely to eventually have a good outcome. So, don't lose hope. If you have a patient who's coming in or participating in a treatment or a treatment program who's still using, this first phase of treatment really is focused on helping the youth develop more insight into what's happening, the fact that an SUD is there, and to help them kind of move along this continuum of motivation or change in which they might go from being very ambivalent about giving up the substance use to becoming quite invested in making that change and aware of how the substance use is making their life worse, not better. And then that's where we can really start to see some changes in those in regard to the actual use patterns and behavior. And if you have a youth who is refusing to engage in treatment or even come in to your office for checkups, there are still things that can be done. There are a number of family-based approaches that don't even require the youth to be involved. One is it's also kind of called CRAFT, but it's community reinforcement and family training. And this is a sort of manualized approach that involves helping parents develop ways of interacting with their teen or loved one that have been shown to not only greatly increase the likelihood that eventually that young person will engage in treatment and stay in treatment, but also have been shown to lead to decreased use for that young person. And this approach generally involves positive reinforcement strategies, allowing for natural consequences, and improving the relationship between parent and child. And this is a really important one, and I think another place professionals can really help. Helping one, providing support to parents so that their level of anxiety can come down a little bit, and reminding them that they are still a very important part of their child's life, even if it seems like their child is totally disinterested and doesn't seem to care anymore. That's almost never the case. Research shows that the most important thing a child needs to be resilient and achieve optimal health outcomes by adulthood is a committed, caring adult in their lives. So champion the parents' involvement and persistence, and reminding them that this is a long road and it can take some time before we see concrete change, but that their efforts matter. It's helpful to also remember and help youth and parents remember that treatment, especially in the early stages, is a process of figuring out what's going to work. There's not, one size fits all approach to this. What works for someone can be quite different than what works for another person. And so there's going to be some bumps in the road. We will often see, two steps forward, one step back. And that's okay because we're getting more information and we're figuring out what works and what doesn't work. Generally, though, tough love or punishment-based approaches rarely work in the long run and can result in worse outcomes over the long run. And short-term, high-intensity treatment, like we might see in the movies, etc., also tends to not be the most effective approach. And 30-day or less sort of high-intensity rehab treatments generally have been shown to be no more effective than no treatment at all. So we really want to remember and help families remember this is a longer sort of game or approach that we're engaged in here, and to build something that's going to work over the long run. Here's a list of sort of red flags about programs that may not be as high quality as others. And you can review these at your own time later if you'd like. And here, whoopsie, here's a list of resources that I love, that I have found very helpful over the years, that families report are really helpful, and that I think for a busy pediatrician or clinician who does not have specialty training in this topic can find really useful. So the American Academy of Child and Adolescent Psychiatry has Facts for Families guide on this topic. There's a group called the Center for Motivation and Change. They are based out of New York City, but they have a number of free or low-cost guides for parents, and some, I believe, free or very low-cost groups on Zoom for parents who are either have a teen or a young adult who's struggling with SUD or who's in treatment, and some very practical approaches about how to help that child, even if the child is not currently engaged in treatment. And then perhaps my favorite one here is Partnership to End Addiction. They have a wealth of resources on their website. They even offer text-based support to parents, and everything on there is very evidence-based. So I would say that that's generally the best first stop shop if you're looking to print out or provide a parent or a youth with some good information about what exactly do I do to help my kid with this substance use or substance use disorder related problem. And that's all I have for today, but I'm happy to answer any questions.
Wonderful. Thank you so much for this great talk. A number of questions have come in. First one is, how do you talk to parents who are hesitant about starting ADHD medication because of a fear that their child will become addicted to the medication or develop other substance addictions because they were placed on ADHD meds?
Yeah, that's a great question. Something that does come up, not necessarily infrequently. I mean, really, I'll want to hear first more about, where their concern is coming from. I want to know if there's a family history of addiction or, um, other sort of related concerns. And then really, I'll just share with them the research and the evidence that is out there that, this is a question that has been looked at for decades in many different studies. And there's an overwhelmingly large body of research that shows treatment with stimulant medication for individuals who have ADHD, particularly during childhood or adolescence, is not at all associated with a greater risk of developing an SUD. And then that research, well, also tends to show that it can reduce the risk of SUD. There's a little bit more mixed research in regard to that realm, but I think we can very confidently say that providing treatment for ADHD does not increase the risk of developing either a stimulant addiction or any other addiction, and it tends to be a helpful preventative approach with regard to SUD as part of a bigger sort of treatment plan for whatever that individual is experiencing.
Thank you for that guidance there. And I actually thought that your graph on the
Uh-huh.
risks, right,
Yeah.
of like
Yeah.
addiction, so maybe you could go back to there as I'm reading off the next question here. Um, there's a question that came in about anything that could be used to treat methamphetamine addiction or meth addiction, including off-label.
Ah, okay. Yeah. Yeah, right now we don't, I mean, there's certainly no FDA approved medications for methamphetamine addiction. There's a small body of research showing some trend toward improvement in methamphetamine addiction with the use of certain medications such as Wellbutrin or mirtazapine for individuals who also have opioid use disorder, Suboxone or Vivitrol might be helpful. But again, this is sort of a small body of research, certainly not enough to say definitely we use those medications. And again, none of that is FDA approved. Really, the mainstay of methamphetamine use disorder is behavioral treatments, psychological treatments. Contingency management can be really helpful. That's providing rewards or incentives to individuals as they obtain increasing abstinence from methamphetamine use.
Along a similar vein, another question came in to provide dosages for NAC and Topamax for cannabis treatment. I think there's some people on the front lines like
Yes.
addressing these. And so if you want to go back to that slide, perhaps to kind of go
Yes.
into some of those details there.
Yes, I can't remember if my slide showed doses, but it doesn't. But what I can tell you, so NAC, the research that was done there, and again, it's really just a couple studies, and the research on NAC didn't really end up panning out for adults with regard to improved cannabis use disorder outcomes. But there's namely one study in adolescents that shows NAC uh, seems to help reduce cannabis use and cannabis use disorder. And I believe they use 1,200 milligrams twice a day. And then I think the other one was Topamax or topiramate. Again, not overwhelming evidence that topiramate is helpful with regard to cannabis use disorder. The adult research shows some efficacy with alcohol use disorder. And if you're working with an older teen, it would be reasonable to presume that that might be a medication worth trying if some of the more evidence-based ones like naltrexone have not been helpful. And those dosages, actually, I can't say off the top of my head what it would be. I imagine like 200 milligrams, between 100 and 200 milligrams a day.
Thank you for that.
Yeah.
A question came in about availability of substance use programs, specifically here in the Bay Area. But before you launch into that,
Yeah.
I want to make a plug for the care coordination consults that CalMAP offers. So in addition to being able to talk with our child and adolescent psychiatrists, you can either place a consult request online or call in and ask to speak with our care coordinators. And they have these curated resource lists from across California for different kinds of mental health resources that might be appropriate for youth. And so it's going to be a little bit beyond the scope of like a talk like this to be able to dial into like specific resources in most places. But Emily, since you have worked in this area, are there particular SUD programs in the Bay Area that you know of that might be useful for us to know?
Yeah. So, there are programs out there. A lot of them tend to be sort of like a residential level of care, which isn't what the majority of youth are going to need. And they do, um, they're either private pay or some of them take commercial insurance for individuals with Medicaid or Medi-Cal. It can be really, quite a bit harder to find a program, although every county is different. And I'm unfortunately not familiar with the specific services offered in each county. There tend to, I believe, be more transitional age youth resources available than adolescent resources available at a county level. Stanford does have a teen and young adult substance use disorder program. I'm not sure currently exactly what services are provided, but last I checked a couple of years ago, it was like generally outpatient services, not IOP or higher levels of care. UCSF used to have a youth substance use disorder program, but does not currently due to grant funding limitations.
Well, thank you for that. And so please do feel free to consult our care coordination team if you've got specific questions on those lines. Um, if you could go ahead and let's switch over to having Rita share our check-in QR code. So if you could stop sharing here and then Rita can flash up our QR code. Rita also dropped the link in the chat to claim credit for today's session. So please feel free to do that now. One last question in this, I'll go ahead and pitch this to you since we have a little time. Can you comment a bit on the physiology of drugs of choice? Why do people choose certain drugs over others preferentially? Is there anything that's known about this?
Yeah, it's actually a really interesting question. And I would say there's definitely debate in the field. Like there's, a lot of times people think about self-medication. So people may choose a substance that is treating, you know, a symptom or an issue that they're experiencing. So if someone's having difficulty with attention and focus, maybe they'd gravitate towards stimulants, whereas if they have a lot of anxiety, maybe they would gravitate more towards alcohol. And, I would say the research is sort of split or torn on the, validity or degree to which self-medication plays a role. I mean, I think it almost certainly plays some role, but is not really the deciding factor with regard to does someone actually become addicted or progress to an SUD when, that the risk factor there tends to be related to exposure and genetics. Another really important determinant really is what's happening in the environment. Like, across sort of cultures and countries, we see really different rates in regard to what type of SUD is most prevalent. And a lot of that has to do with sort of supply, like drug supply. And we clearly saw this with the opioid epidemic. And then another thing is sort of knowledge and perceived risk. We definitely see certain drugs of abuse coming in and out of fashion. And there's something called generational forgetting, which refers to sort of the theory, which I think has some validity, that as a specific drug becomes epidemic and problematic within a generation, people become more aware of the harms or risks associated with using that drug, and it tends to go out of style. We kind of saw this with heroin during the 60s, and then another drug um, will sort of take its place, in that case, kind of switching more towards cocaine or methamphetamine during that particular generational shift. And rates of SUDs amongst the population at large, at least in our country for the past several decades, have stayed fairly persistent overall. It's more the drug of use shifts, although there are some exceptions to that. But I think that speaks again to the genetic and other sort of psychiatric and universal environmental risk factors that exist and don't necessarily change as much over time that are common to the liability of developing a substance use disorder more generally. So I hope that answers the question.
Wonderful. Thank you so much. I don't see other questions here right now. With that, I want to thank you so much for giving this wonderful talk today, Dr.
Thanks
Fakhani,
for
and thank you
having
so
me.
much for all who were able to spare some time out of the very busy lunch hour to come join us today. 2 weeks, we will have what I feel is a related talk on motivational interviewing and really helping to engage youth around maybe engaging in some of these resources that we've just talked about if there's a substance use concern or other mental health related concerns. So we hope to see you then. Take care.
Right. Bye.